Yep.
Yes, you can see them?
Yes.
Yep.
Okay, great. Are you getting a gray box that's blocking part of it?
Gray box?
No? Okay. Perfect. Okay, everybody, it's 12 o'clock, so we're going to get started. Today, we're going through the Safety and Maternity Care lecture. It's the only lecture that's now part of the ALSO course. And thank you for joining me today. I am Suzanne Krasovich. I'm one of the faculty at the Waukesha Family Medicine Residency Program, and I'm the course director for ALSO this year. Obviously, we've had to be a little creative this year, like with many things. So I appreciate everybody's flexibility, and I think you're going to have a great course. So today we're talking about safety and ways to increase safety in maternity care. And I will be scrolling through. I can see your chats. If at any point somebody has a question, feel free to put that into the chat box. And if you can't see the content, also please let me know. So just a brief little introduction. You can see in this picture that two penguins trying to communicate, one who's the source of the communication sending a message, and one who's the receiver. And in between those two penguins trying their best to communicate, there's a whole pile of assumptions, distractions, fatigue, things like HIPAA compliance, lots of things that get in the way of trying to hear the message or trying to let someone know that you heard their message. And some of that is what we're going to talk about right now. If you're not muted, I would ask you just to please mute. So this illustration and a lot of the concepts that we're talking about in this chapter are actually derived from the team strategies and tools to enhance performance and patient safety, otherwise known as team steps. And that's simply a program that deals with communication and safety. So today, what we're trying to accomplish is discussing the need for a patient safety focus in maternity care, reviewing some of who's involved as the maternity care team personnel, talking about some of the evidence that team training improves outcomes, showing you some teamwork tools that are known to improve safety, and discussing risk management issues in obstetrics and a few solutions called the 5 C's. So some of you may recognize this picture. If you don't, on January 15th, 2009, US Airways Flight 1549 hit a flock of Canadian geese, lost thrust in both the engines, and ended up having to make an emergency bailout landing on the Hudson River near New York City. That landing was successful, and in fact, all 155 travelers and crew on board survived. Really, the success and the keys to success of that bailout landing were that everyone involved in the flight crew underwent pre-flight training and drills. Everyone knew what their role was supposed to be. Everyone communicated, and that good communication existed between the pilot, the crew members, the passengers, ground control, air traffic control, and the rescuers. Everyone, in other words, was part of the team, did their roles well, and communicated to make that a safe landing as opposed to a disaster. In a similar way, the Advanced Life Support in Obstetrics course involves utilizing a standardized approach to emergency situations. It allows us to have that good communication, to all be on the same page, to know what our roles are, because we know the content we've practiced the manual skills, and we use the mnemonics to decrease the likelihood of errors. When we think about safety, so childbirth is actually the most common reason for admission to the hospital. In fact, coming in to give birth to a child is about 11% of all admissions to the hospital. C-sections are the most common operative procedure in the United States. But poorly managed births contribute to the estimated 289,000 maternal mortalities worldwide every year. Medical errors are actually the third leading cause of death in the United States after heart disease and cancer. Between 210,000 and 400,000 non-pregnant patients in the United States die annually due to medical errors. And in fact, the non-lethal errors are probably about 10 to 20 times more common than that. The Institute of Medicine report showed that 7% of hospital patients experience a serious medication error. And again, more Americans die of medical errors than they die of breast cancer or AIDS or motor vehicle accidents. There are costs associated with that as well, $8 to $29 billion annually. So obviously there's a lot of interest in how we can prevent or minimize those medical errors. From 2004 to 2014 in the United States, communication failures were considered a root cause in 48% of the maternal sentinel events and 70% of the perinatal sentinel events. So again, communication plays a huge role in what happens with medical errors. It all comes down to the fact that just because you have a team of experts, that doesn't mean you automatically have an expert team. Most maternity care units involve so many clinicians, and it's not necessarily all the same people on any given day. So you can see the example here. This would be a large unit, and you might think about how this relates to your own unit. But if you had 81 different OB or family medicine OB providers, 50 different nurses, 16 anesthesiologists, 12 NNPs, 14 surgical techs, and 35 nurse anesthetists, you could end up having 381 million different combinations of possible teams. Now, even if your hospital is not that big, the end result is the actual team that you work with on any given day can be a combination that's one of hundreds, which means that practice is key. So if we go back to our US Airways pilot and flight attendants who were on that plane, they were an example of a high functioning team that had practiced what to do in an emergency. We know that patient outcomes improve when team members work together in an environment where practicing team training is considered a high priority. We have actually good evidence that teamwork improves outcomes. So in one example, the weighted adverse outcomes score and maternal severity index, so two different measures of outcomes, both improved 50% following implementation of team training in the maternity care unit at Beth Israel Deaconess Medical Center. And in another health system in Minneapolis, they also found improved obstetrical outcomes when they did team trainings. So I'm going to give you just a couple of examples of some communication tools, two that we'll talk about, the 2-challenge rule. And here you'll notice that in the first frame, one penguin is trying to talk to the other, who's clearly not listening. In the second frame, they're still trying to talk, and now that second penguin is maybe starting to listen. So if somebody has said the same thing to you twice, if you've gotten the same phone call from a concerned nurse more than once, you need to really think, okay, what's prompting this second call with the same concern? We can also look at what we call cuss words. So specifically, I'm concerned, I'm uncomfortable, or this is a safety issue. When you hear those words or when you use those words, that's a way of communicating to another person on the team that this is something to pay attention to. We look at who's on that maternity care team. So that team actually includes the pregnant woman and her family or support network, as well as the healthcare team, which might include a birth attendant, consultants, nursing personnel, maybe even a doula or some other type of support person. From the aspect of the pregnant woman, things that you can do to help communication with that woman include listening and encouraging mutual trust, anticipating potential problems, really discussing options, and developing an acceptable birth plan, allowing the woman to have a sense of control whenever possible, and assessing for any entrenched health beliefs, expectations, or concerns that might be framing how your conversation is going with her. We can use patient-centered interviewing and shared decision-making techniques to promote effective provider and patient communication. If we're talking about the family and the support network, it helps to develop a relationship with the partner and the family prior to the time that you're in the hospital, if you can. It also helps to have an idea of what their cultural norms and expectations are, and if any of those might be part of what you need to take into account in your communication. It helps to assess family dynamics and encourage attendance at childbirth classes. Even if people don't feel like they need the specific information from a childbirth class, just setting up consistent expectations and a consistent language for discussing what's happening in labor can help make that communication go more smoothly. And if there is anger or anxiety expressed, either from the family or from the patient, you want to make sure to acknowledge that. When we look at the healthcare team, a well-functioning team actually improves patient satisfaction. That means we can do that through not only that good communication, but also having the birth attendant, the family doc, the obstetrician, the midwife, whoever that is, be readily available, having any consultants willing to assist in a timely manner, and respecting and encouraging contributions from anybody on the team. It's also very helpful to have practices and simulations together as a team in preparation for obstetrical emergencies. Those are the things that help keep that team functioning well. So some other characteristics of highly effective teams. Teams that work well together and work in a highly effective way usually share a mental model. They have the same idea when they walk into that room with a shoulder dystocia of how you're going to approach that. Everybody on the team knows what their roles and their responsibilities are, and they have a clear shared vision. There should be strong team leadership, regular practice and debriefing of feedback, and a strong sense of collective trust and confidence. The team should cooperate and coordinate, as well as optimizing resources to manage their performance outcomes. There are going to be times, even with the best, highest functioning team, when the patient and the clinician or the patient and the team disagree. You're not on the same page. When that happens, you want to make sure that you document the conflict, including the patient's understanding of the implications and the decision not to follow the recommended care plan. You want to document any limitations that imposes on you, the provider, as a result of the disagreement with that treatment plan. And if you feel it would be in the patient's best interest that they might do better with another provider, you want to make sure that you take care of that transfer in a timely manner. Within the team itself, conflict can get in the way of team function, and that might mean personality conflicts, different competitive pressures, certain fixed beliefs about abilities or roles. That's not something I can do as the provider, or that's something that only the nurse should do. Biases regarding management, and sometimes inadequate resources. So how do you approach that? Well, the first thing is you want to separate the people from the problem. So we say you want to be hard on the problem, soft on the people, rather than making it about an individual, really trying to address what exactly the problem is and what the best solutions are. You want to focus on interests, not positions. So how do we get to a certain outcome, or how can we focus on a particular concern rather than digging into a specific position? And it's helpful to brainstorm and think about any available options for mutual gain. How do you turn this situation into a win-win situation? And finally, you can insist on the use of objective criteria. So often we talk about the best evidence or a particular policy or protocol. It provides a basis for further improvement. So let's talk about a couple of teamwork tools that the team can use. Just like learning the medical part of also and practicing the hands-on, we also want to practice some of these teamwork tools. And some of those important concepts and tools include these 4 things: situational awareness, standardized language, closed loop communication, and a shared mental model. So let's talk about situational awareness, and specifically on labor and delivery. So situational awareness speaks to being aware of everything that's going on rather than getting so focused in on one particular thing, because that might actually distract you from something else important that's happening. So for instance, on labor and delivery, if everyone is staring at the strip, the fetal heart tracing, you might actually be completely distracted from a worsening blood pressure, or even a patient who's seizing or having other symptoms. Or you might be focused on some sort of difficult family dynamic, and that may actually distract you from preparing for a shoulder dystocia, even though you're aware of some potential risk factors, like a large estimated fetal weight or a prolonged second stage of labor. So there's a video that also used to always show. It's kind of a classic psychology video in which a group of 6 people are standing around in a circle. 3 have white shirts and 3 have black shirts. And each of the groups, the white shirts and the black shirts, are passing a basketball back and forth to others in their same color shirt group as they move around in the circle. At some point during that drill, a person in a gorilla suit walks through the middle of the circle. Dr. Davis, call the operator, please. Dr. Davis, call the operator. Oops, can you please mute whoever that is? But people are so focused on counting how many times the white shirt or the black shirt team passes the basketball that they fail to actually even notice the gorilla 50% of the time. So again, they were given an instruction to count the passes, and that led to them really focusing in and not paying attention to other things that are happening. So on a team, we can help situational awareness by having different people on the team checking in on some of those things. So if one person is really paying attention to the monitoring, for instance, it might be helpful if you are not that person to be checking on the patient, or to be just letting people know the bigger picture. And also to remind yourself, I need to be aware of the whole situation. when we talk about standardized language, there are a couple of different types of standardized language that we can use, including the call out, the SBAR, and the handoff. We'll talk about each of those. So the call out is simply a quick way to inform all the team members simultaneously when a new critical event arises. So for example, a woman who's having a postpartum hemorrhage, if one of the team members realizes that she has a history of high blood pressure, whether that's chronic hypertension or whether that's preeclampsia, a quick call out, patient has a history of high blood pressure, alerts the managing provider that methergin might be contraindicated, or is contraindicated. So that's a great example of a quick call out that's very helpful. If we talk about SBAR, so this is kind of a standard communication tool in most hospitals. It stands for situation, background, assessment, and recommendation. So this is, again, a format for communicating critical information so that everybody kind of knows what to expect as you go through that communication. And in at least one institution, the use of SBAR resulted in a decreased rate of adverse events that you can see listed below. So from 89.9 per 1,000 patient days down to 39.96 per 1,000 patient days, simply by having everybody use the same structure for their communication. And then finally, the handoff. So whenever there's a transition in care, that is a high-risk time for medical errors and miscommunication. And that can be whether that's a transfer of care from one provider to another, or from one care team to another. So think about when the nurses change shifts, or when a new provider takes over on call, or if you're having to transfer somebody to a different facility. These are all times that are really high-risk times. Effective patient handoffs should include interactive communication. Ideally, that includes the patient. There should be a limited number of interactions, a process for verification, and an opportunity to review relevant historical data. Closed loop communication, or the check back, again, is a way to make sure that what you're talking about is being heard. So pretty simple concept, but the idea is that the person who's giving the message, the sender, initiates the message. The receiver hears the message and provides feedback that they got the message. So if the doctor orders 10 units of Pitocin IM after delivery of the anterior shoulder, ideally, the nurse should repeat back, the physician would like 10 units of Pitocin IM after delivery of the anterior shoulder, as a confirmation that that message was clearly understood. So both people now have acknowledged the medication that's going to be given, the dosing and the route of administration, as well as the timing of that medication. Just a fun little visual. Some of you may have seen this before, but that illustrates difference in perspective. So if you're looking at this picture, some of you will see a young girl facing away from us. You're looking at her ear, her nose is on the left-hand side, and you can't really see her mouth. She's wearing perhaps a decorative choker around her neck. Others of you may see an old lady, and that choker is really her mouth, her lips. What the other group is seeing as the ear is actually the eye of the old woman. And what the other group sees as the young girl's chin is actually the older lady's nose. If you can, try to see it both ways. So It's important that everybody is on the same page when there's more than one way to look at things. And that means having a shared mental model. So patient safety is compromised when all the clinicians are not on the same page. And part of that includes those things we just talked about. So situational awareness, standardized language, and closed loop communication. Those things allow a team to have and develop a shared mental model. The also mnemonics also help create a shared mental model if everybody is familiar with them. So, for example, shoulder dystocia and the helper mnemonic provides a standardized approach and a way of thinking about how are we going to approach this shoulder dystocia that has everybody kind of thinking through the same steps. Another thing we can do to really help the function of the team are briefings, huddles, and debriefings. So briefings really happen before the patient care, and that's a very short team meeting before patient care to review the patient status and that plan of care. Huddles are meetings of patient care that happen during the course of care, and especially whenever situations or important decisions arise. And debriefings occur after patient care and should be comprised of discussions of what went well and what did not go well. When you do your group testing tomorrow or Friday, one of the things you'll be asked to do is actually lead a debrief after your particular scenario, asking the team exactly these questions. So again, some of those sample debriefing questions: what went well and why? What things could have gone better and why? And what would you or what would we, the team, do differently next time to make this better? Debriefing helps improve medical management over time. It encourages teamwork, and it puts the focus on identifying systems issues. Again, instead of making it a specific person issue, it really helps highlight the things that got in the way of the team providing good care. So just a word about fatigue. Fatigue also gets in the way of patient safety. It affects memory, speed, and mood. You can see that adults who have less than 5 hours of sleep per night in studies have trouble with short-term memory, with retention, and with concentration. The Federal Railroad Administration data, and this is a group that really wants to know about train crashes, right, indicate that fatigue is a contributing cause in approximately 29% of train crashes. And it's really part of the reason that we have resident work hours and that we have training around sleep issues. When we talk about drug errors, so electronic health records do help in decreasing drug errors, especially by taking out of the equation legibility. So someone's not trying to read your writing, and also catching and identifying drug-drug interactions. Another thing that you can do to help decrease drug errors is utilize zeros appropriately. So they talk about the rule of always lead, never follow. So if you have a number that's less than 1, you would start with a 0, so 0.3, for instance. But if you have a number that's more than 1, you would never use a decimal point and a 0. So if you're going to say 4, you would just say 4, not 4.0. And then again, regularly using closed loop communication can also help decrease those drug or medication errors. Medication errors are also common after transitions in care. And so good medical records or medication reconciliation processes especially during those times of transitions in care. So on admission, on transfer, on discharge. In the case of a woman on labor and delivery, that might mean on admission and then after delivery, and then again on discharge, is another thing that can really help decrease medication errors. So we're going to talk briefly about common malpractice allegations. So in general, maternity care is a higher risk situation. That's because, for one, you're taking care of two patients, not just one, so both mom and baby. You also have a woman starting out who's usually relatively young and healthy, and so expecting everything to go well. And finally, we have strong expectations, especially in this country, for everything to be perfect, for the delivery to be perfect, for the baby to be perfect. Pregnancy and birth-related malpractice claims comprise the highest rate of all claims in the United States. And you can see here a list of common allegations. So whether it was someone didn't appropriately counsel me on genetics, or manage complications, or provide care either before delivery or during labor, or after delivery, or someone made the wrong decision about the timing of C-section. These are all things that come up regularly. So what can we do about that as providers? Well, first of all, some basic risk management strategies. So thinking about the 5 C's, these are all things that you can do to mitigate some of the concerns that end up escalating into malpractice allegations. So practicing with compassion. Patients need to feel cared for and respected. And that leads right into communication. If you have good communication with patients and with the healthcare team, then there's less likelihood that the patient will not feel that compassion or will not understand decisions that are being made. Competence, of course, is important, and it's important for us to know our own limitations. So when do you get that consultant involved? When do you get the surgical OB provider involved, if that's your limitation? Paying attention to charting is important. So if you don't document it, it's considered that it never happened, right? So if there was a discussion with a patient and going back to that, let's say you recommend a particular treatment plan and the patient disagrees, if that's not charted, then it's hard to go back and talk about how we discussed that and the patient refused to do it. And then finally, confession or open disclosure when medical errors happen. It's pretty clear from the literature that patients prefer this and that telling them of medical errors does not lead to increased malpractice allegations. In fact, if anything, it decreases that likelihood, again, through compassion and communication. And then simulated learning. So that can be either in a simulation lab or it can be in your own maternity care unit on the labor and delivery floor or somewhere else. Getting that multidisciplinary team together to practice managing emergencies when a patient's life is not actually at risk is a great opportunity to help your team function well and to decrease the likelihood that those problems are going to happen that will lead to a higher risk situation. If you have the opportunity to video record those, that's also great and can be useful in debriefing. So in summary, again, just because everybody on the maternity care floor is an expert does not necessarily make them an expert team. Good teamwork, excellent teamwork requires skills and requires practice. We can use some of those skills that we talked about today: situational awareness, standardized language, closed loop communication, and a shared mental model to help build some of the excellent teamwork skills. We can also apply the 5 C's to reduce the risk of malpractice litigation. And we can incorporate teamwork skills and also mnemonics during training and during practice to lead to improved patient care and improved patient outcomes, as well as building that shared mental model of our excellent team. That's all I have for today. Does anyone have questions? If you have a question, you can either unmute and ask, or you can put it into the chat box. Okay, I want to thank everybody for joining me today. And if you are watching this later, hopefully that's helpful to you as well. We'll look forward to seeing some of these team skills as you go through your training over the next 2 days. Thanks very much, everybody.